Testing 1, 2, 3. Can everybody hear me? Testing 1, 2, 3. Okay. Selamat sejahtera, salam Universiti Watan HUKM, and a very good morning to all our highly esteemed consultants, lecturers and specialists, and also all our attendees in today's clinical pathological conference. Today, I have the pleasure of chairing today's CPC, which is by the Department of Gastroenterology, and I would like to introduce our panel. I am Dr. Deborah, and I'm a gastroenterology consultant, and the discussion will be led by Dr. Kok Wei Hao, who is one of our gastroenterology and hepatology specialists, and also Dr. Andi, who is one of our internal medicine registrars, and we also have with us the team from pathology, led by Dr. Fazarina, as well as our highly esteemed colleague from radiology. Today, we have an excellent and exciting discussion regarding a complex case of a patient with low protein. So without much further ado, I'm going to hand this time over to Dr. Kok to start off our discussion. Dr. Kok, over to you.
Hi, good morning, everyone. I'm Dr. Kok, Gastro Fellow from HUKM. Thank you, everyone, for attending the CPC. Today, our CPC, we would like to present a patient, Madam NS, a 65-year-old Malay lady who have underlying type 2 DM and hypertension. She presented to us with increasing abdominal distension for 1 month, and also associated with reduced effort tolerance and bilateral lower swelling. Otherwise, she also gave a history of outer bowel habit for a year. So, Dr. Andi, what symptoms would you like to ask from the patient?
Assalamualaikum and good morning. Thank you, Dr. Kok, for the question given. So, for this patient, I would like to explore regarding any failure symptom in view of patient having bilateral pedal edema, bilateral lower limb swelling, such as any paroxysmal nocturnal dyspnea, any autopnea, or any shortness of breath on exertion. Besides that, I also want to ask any signs of renal impairment, like any proteinuria as well. And then, in view of patient having altered bowel habit, I would like to explore more regarding altered bowel habit. What is the nature of altered bowel habit? Is it alternate with the constipation and loose stool? And the nature of the stool itself, is it any associated with blood or mucus stool? And besides that, I would like to ask regarding any signs of like endocrine, like hyper or hypothyroidism symptom in this patient as well.
Thank you. So, on further history, the patient have complained of palpitation and constipation alternate with loose stools without bleeding on abdominal pain. Otherwise, she complained of loss of appetite and weight loss for nearly 10 kg in 2 years period. And however, she denied any chest pain, autopnea, proximal nocturnal dyspnea. So, on what further history would you like to obtain from the patient?
Okay, in view of the symptoms more towards gut-related symptoms, I also would like to, as a patient, female patient, I would like to explore any signs of connective tissue disease, such as any joint pain, any mouth ulcer, any photosensitivity, or any rashes. Besides of that, I would also like to ask regarding past medical history in this patient. In view of patient was diagnosed as hypertension and DM, so I would like to ask regarding duration, any target organ damage, and also family history of malignancy, has given history that patient having constitutional symptom, any family history of malignancy, or any renal impairment, or any GI malignancy as well. Terms of as we go to the history, in terms of drug history, I would like to ask regarding any supplement or tridenium medication or current drug medication taken by this patient as well.
Thank you. So upon further history, patient herself denied any joint pain, no rash, no oral ulcer, no frothy urine, or any alopecia. So she denied any connective tissue disease symptoms. Otherwise, she also denied any history of taking traditional medication or supplement. And on systemic review, there's no any shortness of breath, denied any symptoms of shortness of breath, and also on assertion, and also history of lung disease. And she also denied any family history of any malignancy. For her past medical history, she had a hypertension for 15 years and type 2 diabetic for 10 years with a HbA1c of latest of 5.3%. Family histories, only medical history noted that her mother had a history of hypertension, and for social history, she's a housewife, and she denied any history of smoking or any drug abuse or any alcoholic intake. Her drug history wise, she on losartan and hydrochlorothiazide started since early of 2019, and she's on metformin 250 mg BD. So what physical findings would you like to elicit from the patient?
In terms of physical findings, so I will go towards general examination to see patient alertness, any Felo, and also any jaundice in this patient. And then I also want to know regarding a vital sign in this patient in view of patient having hypertension, DXT control, and also oxygenation as well. Not to forget, as patient having altered bowel habit with constitutional symptom, I would like to ask regarding body mass index. Either this patient undergo to underweight or obese patient. In systemic examination or specific examination, I will go by system. The first one in lungs, I would like to see any fluid overload symptom like increase in JVP, reduced entry, or any fine crepitation over the lungs finding. In cardiovascular terms, I would like to see dual rhythm normal, to look for any murmur, any gallop rhythm to show that patient in failure. And also for abdomen, as patient having abdominal distension, I would like to see any organomegaly such as hepatosplenomegaly or palatable kidney, and also ascites. And see any pedal edema or any palpable lymph node as well, or skin manifestation in this patient.
So on our examination, patient is alert, pain, not jaundice. Her BMI is 22. She's vital sign is stable with a BP of 112/70, pulse rate of 80, with a respiratory rate of 16, not tachypneic. Otherwise, she also febrile. We noted that her JVP is not raised, the apex B is not displayed, with S1, S2 with no murmur. Other than that, there's no any stigmata of chronic liver disease on examination. Her lungs, there's a reduced air entry at the left lower zone with stony dullness. There's no, on abdominal examination, there's no any hepatosplenomegaly. However, there is evidence of moderate ascites grade 2, presence of shifting dullness. And also there is a pedal edema. So what lab investigation would you like to send for the patient?
For lab investigation, I will go towards routine blood investigation. The first one for full blood count, I would like to see hemoglobin level. Is it in low side, which is anemic side, or any signs of cytosis, which is polycythemia. And besides that, also in view of suspecting, let's say we are suspecting of chronic liver disease, I would like to see any thrombocytopenia. And for WBC side, I would like to see any signs of cytosis like lymphocytosis or any signs of cytopenia as well. I will go through renal function test as well to see any renal impairment in this patient, and electrolyte imbalance as well, like sodium, potassium, and calcium phosphate, and also magnesium. As we know that this patient having ascites, I will go towards to see a liver function test to see any abnormality in the liver function test, like transaminitis or any increase in hyperbilirubinemia as well. And also the most important one, I will see the albumin level in this patient as well.
Thank you. So from what we observed, the HP trend on the initial presentation on November, the HP was 8.8 normostatic normochromic anemia with a palette of 370. They noted the white cell is 14, predominantly neutrophil count. And subsequently, the trend on the latest, when we last saw her on March, noted there's an improvement of the HP to 9.5. Other than that, we noted that the white cell count slowly progressing in increasing trend to 35.4 on the latest, still predominantly neutrophil count. And also, from the initially presentation, the ALP was noted slightly raised since 2021 with a reading of 276, but upon presentation to us on November, the ALP trend was 678. And subsequently, on our latest review, noted the ALP trend reduced more than half to 322. There is no transaminitis noted from the ALT, but we noted the AST did slightly raise from 106 to currently normalized to 59. The albumin level, unfortunately, we noted slowly progressing, decreasing in trend compared to 2021, where initially was 33, subsequently dropped to range to 11, was static for the past 3 months. The bilirubin level was static, that's not raised at all. So from the investigation of the FBC and RFT, Dr. Andi, what would you like to investigate more from these two results that you get?
From full blood count itself, I saw that it's a normochromic normocytic anemia, and also lymphophilia. So I would like to see the full blood count in this patient to see signs of anemia, any signs of hemolysis. In terms of WC count, I would like to see any abnormal lymphoid cell, any blood cell as well, or is it just a reactive in nature? And not to forget, as a patient having normochromic normocytic anemia from the full blood count, I would like to see any nutritional deficiency also in this patient, to see the iron level, is it functional IDA or is absolute IDA as well, and to see B12 folate and B12 folate any deficiency in that investigation. So come to liver function test, we saw that there's a severe hypoalbuminemia, so I need to rule out there's any renal loss in this patient, to see any urine FME and also urine PCR. In terms of increase in ALP, it can be derived from, is it from the liver itself or any like bone, or in pregnant women like a placenta. So I would like to send for a GGT, the glutamate transmittase.
Okay. Sorry, I missed the RP just now. Noted the creatinine is normal throughout the admission. And there's no any electrolyte. There's only slight low potassium with a normal sodium level. So on further investigation, we noted that the iron level is low for the patient with a TSAT36 and a high ferritin. So we noted there's a functional IDA. FPB done that time, noted is a NCNC type of anemia, most likely possible of chronic illness or acute blood loss or maybe nutritional deficiency. And the raise of white cell count possible due to infection or inflammation. Her GGT is 362, and we did proceed with ALP isoenzymes, which shows the ALP of 414, predominant from the liver, which is 363. Her HbA1c was 5.4, normal range. When the urea FP, there's no any evidence of any proteinuria. And hepatitis status and hepatitis C and HIV is all non-reactive. And we also send for the stool CNS and stool CD toxin, which bring negative view from the patient. And we also further investigate where we send the C3 and C4 level, which is all in normal range. However, noted the IgA slight raise of 657 and IgG raised in 1,680. And there's a raise in ANA 1 to 1,000 nucleolar type. However, further investigation for the ANA, AMA, ASMA, dsDNA, and also P-ANCA, C-ANCA, and extranuclear antibody panel is all negative. We did send an anti-TDG level, which is raised 47, more than 20. The baseline was 20. So, Dr. Andi, after noted the blood investigation sent, so
sorry, apologies. Can I just stop you right there, Andi? So now, putting everything together, you know that her anti-TTG is positive. And with her clinical presentation and her laboratory abnormalities, what is your impression at this point of time?
Based on clinical presentation with severe hypoalbuminemia and positive anti-TG, so it more towards small bowel disease, which is likely to be celiac disease in this patient.
Excellent. And what is the usual age presentation of celiac disease?
In celiac disease, as we know that it's a genetic disorder, more towards autoimmune. So the age mostly about in children itself lah, less than.
So this patient is in her 60s, is rather atypical, isn't it? Are there any other causes of celiac or celiac-like disease in this patient that you can think of?
Sorry, Dr. Deb.
Are there any other causes of celiac-like disease in an elderly patient who presents with nutritional deficiencies, low albumin, and also anemia that you can think of in this patient?
In this patient, I could think of inflammatory bowel disease as well.
Excellent.
So, Dr. Andi, what further imaging investigation would you like to order for this patient?
The first one, I will come up with the basic one, which is a chest radiograph. As we know that from the clinical examination, there's a reduced entry and also stony dullness to see any effusion, any cardiomegaly as well. And I couldn't still exclude cardiac cause, so I would like to see any electrical ECG, electrocardiogram to see any signs of previous ischemia or poor airway progression as well. And echo itself, I would like to speak echocardiogram to see EF, which is ejection fraction, to see any abnormality in the valve and to see any signs of infiltration could be seen in this patient, which is like amyloidosis. And ultrasound, as we know that there's a high ILP with transaminitis, so ultrasound HBS will be indicated in this patient to see any focal evolution, to see any signs of biliary dilatation as well. Not to forget, as patient having constitutional symptom with the signs of severe hypoalbuminemia, we need to rule out any occult malignancy. So thus this patient granted for CECT, thorax, abdominal and pelvis as well.
Okay. So we did proceed with chest X-ray, ultrasound abdomen, echo, and CT scan for the patient. So from the X-ray, Dr. Andi, what can you interpret from the patient's chest X-ray?
So this is chest X-ray, Madam NS, which is a PA view, not rotated film. So but you can see her the lung parenchyma still normal, but then there's no cardiomegaly. But what we can see here, there's a blunted of the left costophrenic angle. It shows that it's a third space loss, which is a pleural effusion as well.
Okay, thank you. Then we did an echo for the patient, shows a good ejection fraction of 70% with good LV function, no evidence of a regional wall motion abnormality, and there's a tribal MRTR. We did an ultrasound abdomen on November 2022, which show mild ascites in the abdomen and pelvis. The liver is normal in echogenicity and echo texture, no focal lesion. Portal veins are patent and no dilated biliary ducts, and the gallbladder is contracted. The visualized pancreas and spleen are normal, and kidney are normal in size and echogenicity. No evidence of hydronephrosis, and impression was mild ascites. We did also a CECT tab under UKMC on previously on September when she initially presented to the UKMSC, where there shows a reverse liver spleen attenuation in keeping of a fatty liver. Otherwise, there's a few segmental circumferential bowel wall thickening with multiple sub-centimeter lymph nodes, with the bowel thickening noted more on at the proximal jejunum, ileum, and also the ascending colon. So now I would like to invite Dr. Aini, our radiologist, to present the ultrasound and also the CT findings. Thank you.
Okay, a very good morning to professors, doctors, as well as the fellow medical students. Thank you for attending the CPC for today. So I will be presenting a bit on the radiology part of this patient. This is the ultrasound, HBS, which was done on the 29th of November. So I'll just touch a bit on the ultrasound first, because the CT was actually performed first in September, then the ultrasound. So as by right, basic should be ultrasound first prior to your CT. So for the ultrasound, so we can see that there is this is the liver parenchyma. So normally your liver parenchyma should be not this hyper-echogenicity or hyper-echoic. In comparison to your spleen, this is your spleen. Okay, so your spleen should be more hyper-echoic in comparison to your liver parenchyma. So these features are in keeping with a fatty liver or hepatic steatosis, they call it. Okay, and you can see that the portal vein has normal caliber, measuring 1.2 centimeter. Okay, and then this is just the longitudinal view of the free fluid. This is the area scan at the urinary bladder. So we see free fluid at this particular region. However, it's a simple fluid. Let's see. Can you see the pointer now? Is it there? Right?
I do.
Oh, okay. Laser pointer. Here, right? You can see now? Ah, okay. Sorry for that. I thought the pointer was... Sorry. Okay. Sorry. So we have this free fluid in the suprapubis region. Okay, so it's simple. We don't see any septations. We don't see any debris within. And there is bowel loops. These are just normal collapsed bowel loops at this particular region. And this is the urinary bladder. Okay, so retrospectively, we go back to the CT, which was done earlier on the 23rd of September. Okay, so this is the axial image of the CT abdomen at the level of the liver parenchyma. So as mentioned earlier, I did mention that on ultrasound, you see that the liver is hyper-echoic in comparison to the spleen. So these features are, we mentioned it as being fatty liver. So on CT, is actually the opposite. Okay, so on CT we give IV contrast. So this is a portal venous phase, excuse me, where you can see that this liver shows homogeneous hypodensity in comparison to the spleen. So you can see that the spleen shows more increased homogeneous hypodensity. So we call this as the reverse liver spleen attenuation. These features are typical of a fatty liver or hepatic steatosis. Okay, so this is a reformatted image of in coronal view of the same patient, CT abdomen. So the liver is actually quite enlarged. When we measure it from the craniocaudal view, is actually 19 centimeter, so it's enlarged. The spleen is not enlarged; it only measures about 11 centimeter. So you can see that the liver is enlarged until it pushes the kidney more inferiorly to the pelvic region. Okay, so these are still a reformatted image in coronal view. And this is an axial view. So what we're seeing here, as Dr. Kwok mentioned earlier in the CT findings, we see that the left side of the jejunum, okay, these are bowel loops on the left side of the abdomen. So as we know, left side of the abdomen, small bowel loops are more jejunum, likely jejunum. How do you differentiate? Is because you see these horstrations which are more prominent on the jejunum in comparison to the ileum. We call it as featureless and more feature, right? So jejunum has more feature and ileum shows featureless. Okay. So this, just show you this one. This hyperdensity bowel loops are actually oral contrast within the bowel loops. So you can see that the bowel wall is actually not thickened. It's nice and thin there. So but this particular bowel loop, you can see that there is circumferential bowel wall thickening. Even this one. Okay. So on axial image, similarly you see this bowel wall thickening roughly at the same level. Okay, but taken in axial view, you can see it's thickened, and there are still contrast still flowing within the bowel lumen, so there's no evidence of obstruction. Okay, this is another bowel loop which is thickened. However, there are no pericolonic streakiness. There's no pericolonic fluid. However, you do see some lymph nodes. This one here, and this one here. But I'll show you a nicer lymph nodes in my subsequent slides. This is the right side of the kidney, yeah? So these are normal bowel loops, okay? So you don't see any thickening of the bowel loop at all at this loop, okay? So similarly, coronal view and axial view. So this is a bowel loop which is a bit more inferior compared to the earlier slide. So it's you can see circumferential thickening. So these are normal bowel loops with oral contrast within, hyperdense. This one is a normal bowel loop, thickened bowel loop. So you can see here, there is lymph nodes. Okay, these are the arcades or the mesenteric vessels. Excuse me. Then you can see lymph nodes here. Okay, and this is on the right side of the abdomen, the liver is here. So this is actually ascending colon. And you can see that there is also circumferential bowel wall thickening here, but not as marked as compared to the jejunum. Okay. This axial cut is just to show you the excuse me, the lymph nodes within the mesentery. Okay. Similarly, just a zoom image of the lymph nodes which I showed earlier. Okay. So this is another jejunal loop, slightly more inferior. It's thickened. You can see here, but again, we don't see any streakiness, pericolonic streakiness or fluid. Alright, and then this is in sagittal view, yeah? So it's reformatted in sagittal view of the same patient in CT abdomen. Okay, so I'm just showing you a lot of this because I just want for you to differentiate between a normal bowel loop and an abnormal thickened bowel loop. Alright? Okay, so this is one of the lymph nodes which is slightly bigger compared to the rest. It's about 1.0, 1.1 centimeter in short axis diameter. Okay, so superiorly a bit, you see this another loop at the jejunal side. Okay, this is the kidney, right kidney. This is the visualized segment 6 of liver. Then you can see this another bowel loop thickening. Okay, this is slightly lower down, yeah, in the pelvic. You can see your iliac bone. This is part of the ileum. It's not the terminal ileum because it's not yet at the ascending colon, but it's at the distal part of the ileum. Not as thickened as the jejunal side of thickening, but there is thickening. But there's no mesenteric streakiness, there's no adjacent enlarged lymph node. Okay, just a bit of theory. As differentials of circumferential small bowel wall thickening. So we take normal wall thickening in a distended bowel as 1.2 mm and in a collapsed bowel 3.4 mm. So for a focal, less than 5 cm is the length of the bowel wall. You can differentiate between malignant and inflammatory. Excuse me. For malignant cases like adeno-CA, lymphoma, gastrointestinal stromal tumor, GIST, and less likely metastasis. For inflammatory, any perforation, or Crohn's, and like in this particular patient, we do have this skip lesions, right? So that's why Dr. Andi mentioned of Crohn's. Yes, there's another good differential with asymmetrical bowel wall involvement and diverticulitis. For segmental, that means the length of the bowel is a bit more, measuring from 6 to 40 centimeter. Cases are like you see in hemorrhage. In hemorrhage, we see in plain study, you see hyperdensity in the wall. So in plain study, yeah. And then for lymphoma, I'll just give you a bit of images later on in my slides. Crohn's, infection, ischemia, usually SMA embolus, vasculitis, radiation. So diffuse involvement of the small bowel, usually more than 40 centimeters. Cases more systemic cause lah, like hypoalbuminemia, intestinal ischemia, which is more, the thrombus is lodged more proximal. So that's why the involvement of the bowel is more diffuse lah, more than 40 centimeter. Vasculitis, angioedema, and infectious enteritis. Okay, so a bit on Crohn's. So what is Crohn's? Of course, the detailed part, the etiology, I won't touch for today. I'll just touch on the imaging part. Yeah. So it is a chronic progressive transmural granulomatous IBD, like one part of the IBD. Usually on imaging, there are skip lesions, like in this patient. Okay. Usually asymmetrical bowel wall involvement, and it can affect any part of your GIT. However, almost always affecting your terminal ileum, usually about 95% of cases. And we have this fat halo sign. Okay, I'll show you in one image in my subsequent slide. And of course, besides having this bowel wall thickening, we can have strictures and stenosis, okay, associated with dilatation pre-stenotic. And features are typical. You have this mesenteric fibrofatty proliferation and comb sign. So I'll just touch a bit on these features in my subsequent slide. So this is a fat halo sign. All right, this particular bowel here. Okay, so usually fat halo sign, the best will be depicted on when the bowel is end-on, when the bowel actually comes to you and you image it axial. But I don't have the image, so I only have it in longitudinal view. So it's actually the infiltration of your submucosa with fat. So fat, this is your fat, yeah, subcutaneous fat. So it's hypo, yeah? And that is replaced here at the submucosa. So in between the muscularis propria and the mucosa. Okay, so it is characterized by an inner mucosa and an outer muscularis propria and serosa. So and then there's a ring of enhancement. Can you see here? There's a ring of enhancement of the bowel wall. Okay, so this hypo is your fat component. So these features we see in Crohn's lah. Okay, this is a typical finding you see in Crohn's disease, where we call it as a comb sign. So comb being comb, the teeth of the comb. This is where they call it as comb sign. So it's actually a hypovascular appearance of the mesentery. Okay, and a fibrofatty proliferation is in between these arcades of vessels. All right. So this forms this linear density and the mesenteric side. Okay, and then the affected segment of the bowel lah. This one. Okay. So this gives the appearance of the comb, teeth of comb lah. Teeth of comb. That means comb sign. Okay, so a bit on adeno-CA of the bowel. Usually solitary, unlike in this patient, and it's located within the proximal small bowel. And on CT, we see it usually concentric or eccentric mural thickening, and lymph nodes, enlarged lymph nodes are present in about 50% of cases. So this is another patient who has an adeno-CA of the small bowel. It's an eccentric bowel wall thickening here, and it's solitary in this particular patient. Okay, so I'll touch a bit on small bowel lymphoma. So why? Because it's the most common small bowel malignancy. The sites are usually common in the ileum and jejunum with 60% and 20% respectively. And what imaging findings are of course, wall thickening. And in 30% of cases, we have this aneurysmal dilatation, which is not present in this patient. But of course, if it's not present, does not mean it's not lymphoma. It's just 30% of cases. And the lymph nodes are regional and enlarged in about 50% of cases. And usually there are presence of this enlarged retroperitoneal lymph nodes, and it's quite extensive. And the spleen is enlarged. Okay, so for this patient, we don't see the enlarged spleen. Only the liver is enlarged. Okay, so this is another image showing you a small bowel lymphoma. So usually small bowel lymphoma does not come with obstruction. It comes with this aneurysmal dilatation. So the contrast can still flow through the lumen here. So we can see this very thickened, this is at the distal part of the ileum, yeah? And then there's a lot of fat streakiness surrounding the colon. And there's this huge chunk of lymph node adjacent to it. Okay, so this is a small bowel lymphoma. Okay, so other differentials for this particular patient. For I think Dr. Andi did mention celiac disease. So for radiological wise, for me, I have never encountered and diagnosed celiac disease on imaging. But you can see that this is the ileum bowel loops. This is the jejunal bowel loops. There is actually reverse of the mucosal fold. So by right, you should have this prominent mucosal folds on your jejunal side. Okay, but this is terbalik. You have it on the ileal side. So it's, they call it as jejunization of the ileum. Okay, so I think as mentioned earlier, Andy mentioned it's affecting the children, young adults, and it's actually a disorder of the small intestine mucosa, which is caused by intolerance to the gluten, right? And usually, of course, you diagnose by biopsy. Okay, so I think this is one of my last slides for imaging, just to show you imaging on a bowel ischemia. So we can see that within this green box, this is the bowel loops, right? This is the bowel loops, and you can see that the wall here is actually normally enhancing with fluid content within, right? But at the lower part of the abdomen, you can see that the wall is like poorly enhancing. It's not as enhanced as this left upper quadrant bowel loops. It's still enhancing. It's not like totally no enhancement, but there is they call it as poor enhancement. So with evidence of thrombus, so we conclude this patient as having a bowel ischemia. So in conclusion, for this particular patient, several segmental, circumferential, jejunal, ileal, and ascending colon wall thickening, however not causing significant luminal compromise, and adjacent lymphadenopathy, not big enough, but there are presence of lymph nodes. So there are a few things that we need to think of for imaging wise. Crohn's should be one of the top differential because it is multifocal. There's a lot of segments involved, but points against Crohn's is this patient has a lot of nodes in the mesentery. Okay, and lymphoma is also one of the differential. Okay, however, no typical findings of pseudoaneurysm, but as I mentioned earlier, not necessarily no pseudoaneurysm is not lymphoma. Okay, and of course, this patient has lymph nodes in the mesentery. Okay, and patient has hepatomegaly as well. So for infection, which is usually, of course, gut infection, usually we think of TB, of course, number one, but TB, of course, is usually at the ileocecal junction, and the nodes involved are usually necrotic, unlike in this particular patient. And usually, TB will not have multiple segments involved. Okay, so I think that's all for the radiology part. I'll pass over to Dr. Kortbeck.
Thank you, Dr. Andi. So after noted the imaging from the radiology, Andi, so what would further investigation or procedure you like to do for the patient?
From the imaging and also clinical findings, so it shows that there's a ascites, which is significant ascites. So in this patient, we need to investigate the ascites based on diagnostic peritoneal tapping to send for the serum ascitic albumin gradient, as we know that it will differentiate between portal hypertension or non-portal hypertension. It based on the, if more than 11, so equivalent to portal hypertension. So it will narrow down our diagnosis. Besides that, from the peritoneal ascitic fluid as well, we need to send for other analysis, as we know that this patient having constitutional symptom with the altered bowel habit. We need to rule out any TB colitis in this patient as well, to send for TB peritonitis like serum AFB, serum MTB-CNS, and also cytology as well to look for any malignant cell in this patient.
So during admission, we proceed with therapeutic and diagnostic peritoneal tapping for the patient, where we draw 800 cc straw color fluid. The SAAG is less than 11, and also noted that the peritoneal fluid culture, there's no growth and the cell count was nil. Cytology, there's no evidence of malignant cells, and the TB culture and AFB is negative. Other than peritoneal tapping, what would you like to further investigation for the patient?
From the CT abdomen and pelvis, but we can see there's bowel wall thickening. So this patient warranted for number one, to see any upper GI involvement, as well as one of my differential diagnosis would be inflammatory bowel disease. If let's say it's a Crohn's, it can involve upper GI. So we need to do OGDS, which is esophagogastroduodenoscopy. Besides, as we know that one of the differential as well celiac disease, to see duodenal itself, any atrophy of the villi, and to send for the HPE as well. As we know that there's also thickening over the knee. As we know that some more Crohn's disease also, which is inflammatory bowel disease, can involve a large bowel. So role of colonoscopy here, to see any signs of infiltration. So we can see for the HPE to see any abnormal cells or any signs of infiltration like amyloidosis. That one, I think there's need a special stain, what we say Congo red if not mistaken. And to see any abnormal mass as well. The role of enteroscopy for the small bowel scope also could be warranted in this patient, as we know that there's a small bowel thickening from the scan, which is from the jejunum and also duodenum part.
Okay, thank you, Andy. So this is from the OG scope that we did. So we noted that for at the duodenal D1, D2, there's no any evidence of scalloping, just mild edematous stomach mucosa. So patient did two scope, one at under you can see where it's an antegrade enteroscopy, did until proximal jejunal, where there shows evidence of a linear ulcer there. Sorry, I don't have the image for that. But otherwise, I say the OGDS done by us, there's no any evidence of scalloping at the D2. Then we did proceed with the colonoscopy. Unfortunately, there's a poor bowel prep. Noted at the left images, there's a hematinic stool. So not able to proceed to intubation to the TI. However, at the cecal region, there's no evidence of any ulcers along the scope from cecum to rectum. From rectum to cecum, there is no evidence of any skip lesions or ulcers or any edematous mucosa or strictures. And we did send from the HP for the site. So currently, I'd like to invite Dr. Fazarina for the discussion of the HPE site at the jejunum and also at the colonoscopy sites.
Okay, thank you, Dr. Kok. So good morning. From the histopathology side, we received colon biopsy and also ileum and jejunal biopsy and also duodenal biopsy. So for the colon biopsy, it shows mild chronic colitis, and for the ileum biopsy and the jejunal biopsy, it shows basically mild ileitis, mild jejunitis without any granuloma to suggest any TB or Crohn's disease. There's no cryptitis or crypt abscess to suggest inflammatory bowel disease, and no amyloid. And so I'll proceed now to discuss about the duodenal biopsy. So this is the case. So this is what we received. The duodenum biopsy is multiple fragments of small bowel mucosa, and it is a small bowel mucosa because we can see that. Is there a cluster here? Okay. Yeah. So we know that this is a small bowel biopsy because we can see this villi on the surface of the mucosa, and some of it is a bit partially atrophied. So we go to the higher power. Okay, so these are the small bowel mucosa again with the villi here, and adjacent to it we see this small bowel mucosa with the villi, but it is partially denuded. There's no epithelial lining, and also it's a bit shorter than the villi next to it. It's like this is what we call partial atrophy. It's not exactly fully atrophied or complete, but it's just partly. Okay. And so this is a higher power to show how short it has become, the partial atrophy, and there's no hyperplastic crypts noted. So hyperplastic crypts is a feature of celiac disease. So hyperplastic crypts will be a lot of glands crypts here, but we don't really see that in this biopsy. Okay, so just to refresh your knowledge on normal histology of the duodenum, so this is what it's supposed to look like, projections of villi on the surface mucosa, and the crypts here with no hyperplasia, and this at bottom here is the muscularis mucosa. Okay. So this is the higher power of the crypts, and the lamina propria shows infiltration of inflammatory cells, chronic inflammatory cells like lymphocytes and plasma cells. Okay, and again, there's no cryptitis or crypt abscess, so we don't really see any infiltration of neutrophils inside the crypts here, and also inside the lumen. And this is a higher power again of the lamina propria. Okay. So there's no increase in intraepithelial lymphocytes. We can how we calculate this is we we calculate 100 enterocytes, which is this small cells, epithelial cells that overlies the villi here. We count for 100 and we count how many lymphocytes are there. So this is one lymphocyte here and one lymphocyte here. So if it's more than 40, then there's an increase in intraepithelial lymphocytes. So there's no increase of intraepithelial lymphocytes in this biopsy. And again, higher power, this is showing a lymphocyte here and lymphocyte here. Okay, so we classify celiac disease using modified Marsh-Oberhuber classification. So this is what we do. So we look at intraepithelial lymphocytes in the jejunum, in the duodenum, crypt hyperplasia, and the villi. So for the intraepithelial lymphocytes in the duodenum, it's less than 30, and there's no crypt hyperplasia. However, there is a bit of mild atrophy in the villi, so it doesn't really fulfill the Marsh classification. And this is to compare normal and how celiac disease looks like. Again, the cartoon here. And this is the how celiac disease looks like with almost complete atrophy of the villi. And on the left-hand side here, it is complete atrophy of the villi. Okay, so that's it. And we also did Congo's red stain to exclude amyloid, and it is negative for amyloid. I don't have the picture for this specific case, but I would just like to show you how it's supposed to look like. So the picture on the left is this is duodenum with amyloid. There's deposition inside the blood vessels. Sometimes it can be difficult to see, so that's why we use Congo red stain, which stains salmon pink. So it's mostly in the blood vessels, and also sometimes you can see it in the lamina propria here, or and also the submucosa. Okay. And this is on the left here, there's a picture of another case with amyloid. And this is how the bifringens look like. So usually in your textbooks, you will see a pretty apple green bifringens, but usually in real life in the lab, we don't really see such a nice picture. We'll see occasional some apple green bifringens here and there, with some which is white and some which is yellowish. So we have to concentrate on the apple green bifringens. Okay, so our diagnosis is chronic duodenitis, moderate. Thank you.
Thank you, doctor. In view of time consuming, I'll just summarize the patient. So this patient, initially I have hypertension for nearly 10 years, and initially change of drug, of hypertension drug with Haza, which is consisted of losartan and diuretics, CCZ, and subsequently start to have change of outer bowel habit since 2022, and presented initially to UKMSC on September 2022 with abdomen distension and bilateral lower leg swelling for 2 weeks duration. And subsequently further investigation done, OGDS and also CT scan done. And however, on November, she presented to us again to the ED with abdomen distension, where we done peritoneal tapping, shows from the investigation non-significant result noted. We did refer to gynae team to run any gynae pathology in view of a slightly raised of CA125, also does not show any evidence of gynae pathology. We did repeat the OG and colon, which I have showed the result just now. And on January, she admitted again with worsening outer bowel habit and abdomen distension. So after further investigation done, we treat the patient as a protein-losing enteropathy, possible of drug-induced ARB or celiac disease. And we did have a HB conference and radio conference for this patient, where we concluded there's no evidence of a celiac from the MASH classification. Hence, we conclude this patient is ARB-induced drug-losing enteropathy. And subsequently, ARB was stopped on January, and we did refer dietitian for low-fat, high-protein, and medium triglyceride supplement diet. And we noted that patients have slight improvement clinically, where the pedal edema is lesser and the abdomen is less tense compared to previously. And there's ALP reducing from 678 to 322 with a slight improvement of the HB. Otherwise, we plan for further re-evaluation of the patient 3 months later on June with a repeat anti-TTG and also the OGDS with biopsy. So I conclude that this patient, possible of our diagnosis is a protein-losing enteropathy, most likely drug-induced. So to diagnose, I have a quick one due to time is running out. So for this protein-losing enteropathy, so the diagnosis itself should be suspected in patient with hypoproteinemia, where we have exclude other causes like severe malnutrition, nephrotic syndrome, or chronic liver disease or heart disease. So usually we need an alpha-1 antitrypsin intestinal clearance to diagnose this, where the normal clearance will be normal patient clearance will be less than 30 mils over 24 hours, and the clearance of more than 27 mils per day indicates of a GI protein loss. However, for this test is not available in our center. And otherwise, for protein-losing enteropathy, we have divided to three subtype classification. First, the erosive, where we saw there's a possible of due to inflammatory bowel disease, like UC and Crohn. However, our colonoscopy-wise does not show any evidence of it. Where also GI malignancy for our OG and colon, we have rule out and also with imaging. And for colitis due to C. diff, our stool itself have ruled out C. diff, and during colonoscopy, we did not show any pseudomembranous colitis. For non-erosive GI disease, celiac itself, we have taken a biopsy, does not fulfill the MASH classification. Otherwise, for our patient, the one test that we did not do is the genetic, where we did not send the HLA, DQ2, and DQ8. Other than that, tropical sprue, patient did not have any evidence of it. Or also, from the HB itself, there's not any shows increase of eosinophilic, which we have ruled out eosinophilic gastroenteritis. And the collagenous colitis itself, it does not show any thickening of the lamina propria. And SLE itself, we have did the connective tissue disease, which has ruled out SLE. And also for giant hypertrophic gastropathy, miniature disease itself, our OGDS does not show any thickened gastric folds. H. pylori gastritis, I say we did a CLO test during our OGDS, which is come back negative. And amyloidosis itself, the HPE does not show any evidence of conglomerate stain. Lastly, disorder causing increased intestinal pressure or lymphatic obstruction, where usually we can see in primary intestinal lymphangiotaxia. However, this is present in very young age. And also secondary lymphangiotaxia, example like heart failure, where we echo itself have ruled out that, retroperitoneal fibrosis, TB, lymphoma, or neoplastic lymphoid invasion. The echo have helped us to rule out a few things, where right-sided heart failure or constrictive pancreatitis. And CT itself does not show any evidence of cirrhosis. So here I would like to discuss a bit about the systemic review of drug-induced, where ARB, angiotensin II receptor blockers, causing a GI effect resembling sprue-like enteropathy. This paper was on 2019, where itself they study of a case report and also case studies of 248 cases, where the ARB most commonly reported is olmesartan, and also at the same time the period between ARB initiation and onset of symptoms losing enteropathy start from 2 weeks to 13 years. And mostly are more seen in female. The age of range was around 45 to 89 years old. So from the histology result, we noted that the drug-induced enteropathy itself, there's evidence of villus atrophy and also intraepithelial lymphocytosis. And also there is around 70% presence of HLA DQ2 or DQ8 in a patient who having drug-induced losing enteropathy. However, we noted that gluten exclusion from the diet itself failed to resolve the symptoms, as it is not celiac disease. And from the study itself noted that there's a remission of symptoms seen in the patient of 98% after completely discontinuation of the ARB drug. So there's a study by Madri et.al., where they studied around 2,900 patients with villus atrophy recorded between the three years of 2005 to 2008, where they studied around the ARB and ACE inhibitor patient, where they noted there's villus atrophy noted in those patients, around 2% in ARB and around 5.6% seen in ACE inhibitor patient. But however, during this study itself, the drug olmesartan was not available in Sweden. So that's why that's explained the low percentage rate seen in the ARB. However, in a France study by Basir, they identified adults initiated ARB or ACE inhibitor for 5 years, 2007 to 2012, with a discharge diagnosis of intestinal malabsorption, where they shows that there's an increased rate ratio of hospitalization due to intestinal malabsorption due secondary to olmesartan users. And there's also a study by Yut-al, that one is done at Korea, and a study by Mafatenia. So that in this, they shows that the patient who initiated treatment with ARB and ACE are reported patients who are initiated treatment on ACE or ARB, and they have reported hospitalization with a discharge diagnosis of intestinal malabsorption. The study itself showed no significant difference between the rate ratio of hospitalization for due to ARB or ACE user compared to olmesartan users. So the mechanism itself due to the drug itself is unclear. ARB itself may inhibit transforming growth factor, which maintain gut immune homeostasis. So the variable delay in onset of symptoms after ARB use is due to possible or cell-mediated immunity damage rather than type 1 hypersensitivity. Also, we noted from the there's two types of angiotensin receptor, AT1 and AT2 in the gut. So AT1 the function, AT1 the receptor is function is maintain gut homeostasis, but AT2 receptors induce cells apoptosis. So ARB itself have more affinity towards AT1 receptor and has saturated this receptor, so allowing the circulating angiotensin in our body to bind to the unexposed AT2 receptors, having caused intestinal cells apoptosis and also bilious atrophy. We also noted there's a few case report regarding weight loss secondary to drug-induced olmesartan, where itself we did the adverse drug reaction probability scale, where the probability is 7 for this. So, and also itself, from the few case study itself, noted that usually it takes around 1 to 2 years follow-up for the patient to increase back their weight and also their albumin level. So my take-home message is simple. Diagnosis of protein-losing enteropathy should be suspected in patients with hypoproteinemia once other cause of other common cause like severe malnutrition, nephrotic, or chronic liver disease has been ruled out. As say, alpha-1 antitrypsin intestinal clearance is the primary and most common test performed to diagnose protein-losing enteropathy. So we need a proper good history and also clinical examination, and also other specific tests to rule out the other possible cause before we diagnose itself, and we need to know the pathological cause so that we need to treat the underlying pathology as is the mainstay of the treatment. Also, dietary modification play a critical role in management of protein-losing enteropathy. Thank you.
Thank you to our excellent panel for a very insightful and illuminating discussion. So I think to sum up the case, this patient has got losartan-induced protein-losing enteropathy, and this is a diagnosis of exclusion. Similar to Dilly, we demonstrated that there was a temporal relationship. There was an improvement in her symptoms and also in her anemia as well as her ALP after cessation of 2 months of the drug. And also there have been similar case reports of olmesartan and losartan drug-induced sprue-like enteropathy. However, it must be noted that this is a diagnosis of exclusion. Hence, all other secondary clauses need to be thoroughly investigated before coming to this diagnosis. And in this case, gluten diet-free does not help, and the treatment of choice is cessation of the offending drug as well as high-protein diet. And symptom resolution takes about 3 to 12 months, and the lag time is due to the ability of the AT1 and AT2 receptors to regenerate, which explains why her albumin is still lagging behind, and in some patients it takes up to 2 years for it to completely improve. So with that, I would like to thank our audience for their kind attendance as well as keen attention, and we look forward to the next CPC next Wednesday. So thank you, Salam Watan University, and see you again, and take care.
Terima kasih untuk kehadiran hari ini yang amat memberangsangkan. Tetapi ini adalah CPC yang terakhir sebelum bulan puasa. Kita akan jumpa lagi. CPC akan diteruskan pada 17 Mei. Okey, tunggu pemakluman daripada kami. Kami akan buat edaran pemakluman. Terima kasih. Kita ada kuisis minta pihak teknikal untuk memancarkan kuisis. Okey, kuisis untuk undergraduate, okey. Untuk undergraduate, kerana dalam ASK kita ada anugerah untuk mata komunikatif paling banyak pemenang kuis untuk undergraduate. Main kuisis dulu ada kuis.